Hey guys, welcome back to part 2 of this lecture. We're going to spend time during this lecture talking about RSI, and we'll also spend some time talking about physiologic challenges that we might face when intubating a patient. If you remember from the last lecture, we talked about identifying the difficult airway, the anatomically difficult airway, but also a physiologically difficult airway. So we'll talk more about what that means in this lecture. All right, so the 7 Ps of RSI. This is a great way of, again, that mental checklist of going through all of these steps when you're preparing to intubate a patient so that you have everything you need, you've done everything that you need to optimize this procedure. So the first one is preparation in general. Make sure that you have all the tools that you need to get done what you need to get done. The second one is pre-oxygenation, and this is a big one. I think that we could do a little bit better at this here at Cape Fear. I think it happens on our patients, but I think that we could be a little more purposeful about its happening. The third P is pre-intubation optimization, and this is really that physiologically challenging airway, recognizing that it's going to be physiologically difficult and mitigating those difficulties. The fourth one is paralysis with induction. Obviously not in that order, but I think they had to put paralysis first to make the whole P thing work. Number 5 is positioning of the patient. Number 6 is placement with proof. And then lastly, but also important, is that post-intubation management. All right, so preparation. We all know the IV O2 monitor. But I think that it's both a blessing and a curse. We are very spoiled to have respiratory here, and they're great at their jobs. They have everything ready to go. They do all of that for us. A lot of times we as residents show up to our intubation with like our blade in our hand, if anything at all, and that's it. And we just let everyone else do it for us. But I would encourage you to pretend that respiratory doesn't exist and they're not there to help you, because you might find yourself at your next job in a place where you don't have as great or robust of a respiratory therapy staff, and it's you. You're on your own to have everything that you think you're going to need, as well as testing everything. Make sure that the balloon, the cuff works on the tube. Make sure that the light works on the blade, or the camera works if you're doing video. Make sure that your suction works. You've got the right tubing that you need. And similarly, make sure that you have equipment for plans B and C. This will sort of force you to make a plan B or a plan C. So even if you think this is going to be the simplest, slam dunk, easiest of airways, you've already sort of thought in your head, just in case something doesn't go well, what am I going to have? I'm going to switch to direct, or I'm going to do the bougie. Or what are my rescue plans? If I can't get the tube in, what am I going to do? Am I going to bag the patient? Am I going to use an extraglottic device? And you have all of that ready for you to go right next to you. Not necessarily open, but it's ready. And you also have all the people that you think that you might need. The second P is pre-oxygenation, and I put a big gold star by this one because I think this is really important, and I'm not sure that we do this as consciously as we could. So the whole purpose of pre-oxygenation is to wash out nitrogen, to fill all of our lungs, our dead space, every possible inch that we can with this O2 reservoir. So that enables us to have a longer and a safer period of apnea. Now, they've studied this, just like lots of things with airway, and the best way to achieve this is to pre-oxygenate our patients in an upright position. So that means head of the bed about 25 to 30 degrees. And this enables us to have higher arterial O2 saturations. We also need 100% FiO2. So a non-rebreather at like 15 liters per minute, which is what it classically goes at, is not enough. We need to get as close to 100% FiO2 as possible for at least 3 minutes. And the purpose of that is we need to fill this functional residual capacity, or FRC, with O2. We want to fill up every inch we possibly can with pure O2 to create that reservoir. Another way that you can get to this is by having your patient do 8 vital capacity breaths. So that's like the biggest breath they possibly can take in till they feel like their lungs are about to burst, and then let all of that air out. Again, needs to be at 100% FiO2, but if they can cooperate with you and do 8 vital capacity breaths, you might be able to achieve that pre-oxygenation at less than actually 3 minutes. And then we have to use flush flow. So what do I mean by that? Again, using that non-rebreather at 15 liters is not actually achieving 100% FiO2. You have to crank that little dial and get this ball to go all the way up to the top, as high as it'll go. And if you look closely at the little the oxygen apparatus, it'll have a little sticker on the side that tells you it's max flow or it's flush flow. In this case, it's 40 to 60 liters per minute. So that's way higher than 15 liters per minute. Crank this thing. You've got their non-rebreather on, or actually an ambu bag has been shown to be superior to non-rebreather. Usually it gives you a little bit of a better seal. But either way, you've got whatever it is that you're using to pre-oxygenate, you've got it on, and you've got it cranked all the way up to flush flow for at least 3 minutes prior to intubating your patient. Then the last thing on here is apneic oxygenation, and again, I think this is something that is not consciously done as much as it could be here. So apneic oxygenation, you're going to put on a nasal cannula underneath your patient, or on your patient underneath whatever it is that you're using, whether it's the ambu bag or the non-rebreather, the BiPAP, whatever you're using for the pre-oxygenation, you'll have a nasal cannula as well. This means you need a second source of oxygen, so either another tree on the wall, or you can use a tank underneath the stretcher. You're going to initially have that at as many liters as the patient can handle. So, 2 liters, 4 liters, whatever your awake patient can handle. But as soon as you push those RSI meds, you're going to be cranking that up all the way as high as 15 liters per minute. And that way you've got lots of high flow apneic oxygenation as well. All right, a quick note about delayed sequence intubation. If you've heard about that, what does that mean? The whole purpose of delayed sequence intubation is to facilitate those things that we just talked about on the previous slide. It is to enable us to be able to pre-oxygenate an otherwise combative or altered or uncooperative patient. So this is a question actually from Roche Review. So this is something, I just got this question recently, something that we will be tested on. And it reads, in general, you've got a patient in respiratory distress, they're altered, they have an O2 stat of 85%. They are having worsening mental and respiratory status, and you decide this patient needs to be intubated. You're trying to pre-oxygenate them because 85% to start is no good, but this patient's altered. He is pushing the BVM away. He won't even tolerate the nasal cannula. What do you do next? And your choices are, you're going to place a non-rebreather and just give those RSI meds. You're going to attempt a BiPAP on this patient who won't even tolerate nasal cannula. You're going to perform delayed sequence intubation, or you're just going to say to hell with pre-oxygenation. You're going to do RSI and then pre-oxygenate after the RSI meds are given. And no surprise here, the answer is going to be to perform delayed sequence intubation. So what does that mean? Basically, it means ketamine. It means you're going to give these patients enough ketamine to disassociate them so that they can tolerate whatever form of pre-oxygenation you're doing, whether that's non-rebreather, BiPAP, whatever. So that is what is meant by delayed sequence intubation, and the whole purpose is to facilitate pre-oxygenation. And the reason that pre-oxygenation is so darn important is kind of shown on this graph here. This is a normal, healthy 70 kilogram adult patient. You have about 8 minutes apnea time for this patient before they are going to desaturate below 90%. And if you look, for all of these curves, as soon as they hit that 90%, they all tend to pretty precipitously drop off. So healthy adult, you make them apneic, you've got about 8 minutes. That's usually plenty of time to secure an airway. Compare that to, if you look over here at this purple dot, this is a normal, healthy 10 kilogram child. Because they're smaller, because they're more metabolically active, we've only got about less than 4 minutes before this child is going to clinically significantly desaturate. And then look at this obese patient. This is a, relatively otherwise healthy, not septic, say obese adult. Because of their body habitus, they have only about 3 minutes of apneic time before they are going to go from 100% to below 90 and then fall off that curve so fast. So compare all of these are normal patients, comparing all of that to now you've got this moderately ill. This is a 70 kilogram adult. They're sick, they're septic, whatever. In this patient, you've only got about 5 minutes. For the 70 kilogram adult, imagine what it would be like for a septic or a super sick obese patient or a super sick kid. So giving yourself as much of that O2 reservoir, as much pre-oxygenation as possible to buy yourself some time while you're securing the airway is going to be super important. All right, the third P is our pre-intubation optimization. Is this going to be a physiologically difficult airway? So think about a patient who appears to be in shock. They've got a really low blood pressure. You're going to do early use of pressors before you even bust out those RSI meds. You've got your pressors going already. If they're showing evidence for myocardial depression, maybe, do they need more preload? Do they need blood? Do they need fluids? Or do they need a little bit of inotropic support? If there's some sort of an inability to pre-oxygenate, kind of like the patient we talked about before with the SATs of 85, do you need to step up your game by putting them on high flow or putting them on BiPAP? Or maybe you need to do delayed sequence intubation to get that O2 set up before you actually push your RSI meds. The airway course talked a little bit about excessive sympathetic response. So patients with increased intracranial pressure, maybe some sort of dissection, something where the sympathetic tone is crazy high through the roof, and crashing them down with your RSI meds is going to be pretty precipitous. So they talk about consider fentanyl, like huge doses of fentanyl. I don't know about this. I personally think that it's something that's interesting to think about. I'm not sure if I've come across this situation personally, but something that they're teaching in the course, and so I thought I'd throw it in for completeness sake. And then obviously, if your patient has something like a tension pneumothorax, you're going to treat that with a chest tube. So again, they've done a lot of studies about this, and those patients who are hypotensive prior to intubation are 6 times more likely to code within 15 minutes status post-intubation. Similarly, those patients who are hypoxic are 3 times more likely to code within those 15 minutes. So just like the mantra states, always remember to resuscitate before you intubate your patient. Okay, the fourth P is some paralysis with induction. So we know we're going to give both meds as a rapid push, hence the R and RSI. And then these are the dosing for these medications has really been simplified a lot. So you've got your neuromuscular blockers at the top there, and then some of your induction agents, all at 1.5 milligrams per kilogram. So basically, if you get flustered or when in doubt, you're going to remember 1.5. You usually can't go wrong with that. Obviously not with etomidate, that stays 0.3 milligrams per kilogram. A quick note though on the dosing. So for induction dosing, you really want to use that ideal body weight. Remember that there's like a normal sized patient trapped within your large obese patient. So for your more hemodynamically significant medications, which tend to be your induction agents, you want to go off of your ideal body weight. But for your neuromuscular blockers, go ahead and go off of total body weight. General rule of thumb, induce, like we just said, with ideal body weight dosing, or think about decreasing the dose in hemodynamically unstable patients. If they're already in a shock state, they're going to need less of that induction agent. A few quick notes about both succinylcholine and ketamine. We all know to be wary of succinylcholine, the potential side effect for increased hyperkalemia. But I think, honestly, I never really could remember why or fully understand that, or fully understand why, like, if it was an acute injury, like an acute burn or something, it was okay to give. But, this is something that will come up on tests a lot. So just to clarify this a little bit, normally, in a normal patient, the serum potassium will either not increase or maybe increase by like 0.5 milliequivalents per liter after a dose of succinylcholine. But in some situations, which we'll talk about, the increase in that potassium can be very significant, like up to 5 to 10 milliequivalents per liter actually. Broadly, the two situations where this happens are going to be a patient that's in rhabdo or a patient that has receptor upregulation. And that's the thing where like the burns and stuff come in. Briefly, there are 2 types of acetylcholine receptors that we have. There's mature ones and there's immature ones. And the immature receptors have very low conductance, and they have a really prolonged channel opening times, like 4 times longer than the mature receptors. And so that results in way more release of the potassium, hence your hyperkalemia. So any condition that's going to lead to more of that receptor upregulation, they're going to have more of those immature receptors, and they're the ones that are going to be at increased risk for hyperkalemia after the succinylcholine administration. So that's why when you've got that burn patient, when they first come in, there hasn't been time yet for the body to upregulate those receptors. But a couple days afterwards, they've got a lot of upregulation and a lot of those immature acetylcholine receptors, hence their increased risk for hyperkalemia. Same thing goes for crush injuries. Initially, acutely, it's fine because the body hasn't had time to upregulate those receptors. Severe infections that have been going on for a while, and then something like denervation, so like chronic spinal cord injuries, chronic strokes, multiple sclerosis, ALS, Guillain-Barré, all that stuff that has been going on long enough in the body for it to be able to upregulate its acetylcholine receptors. So that's why we need to be careful with acetylcholine in that particular type of patient. And then a quick note about ketamine. The mechanism for how ketamine works is it actually has a little bit of increased myocardial depression, but it counters that with an increase in catecholamine release. And that second thing was what got us interested in maybe ketamine will be, this wonder drug for induction in hypotensive patients. But when you think about it, a lot of these, again, like septic patients, they have been pumping out these catecholamines for hours, if not days, and their catecholamine reserves are pretty depleted. So if we don't have increased catecholamines to release at all, then all we're left with is this increase in myocardial depression when ketamine is given. So that's really why it's not panning out that ketamine is this wonder drug that's going to increase people's blood pressure when they're super sick. The mechanism doesn't quite work out. Okay, the fifth P of our 7 Ps is positioning. Just remembering that the ear to sternal notch is really the best way for us to get all the airway structures in line. This is becoming slightly less important as we use video laryngoscopy because we're able to overcome a lot of these obstacles. But I think it is something that's still important to think about beforehand. Like, do I need to optimize the positioning of this patient? Do I need to, for my obese patient, really ramp them up to get everything where I need it to be? For my little kiddo with those huge occiputs, do I need to do the shoulder roll, which is the classic teaching, but also maybe do I need to put a little something under the head as well just to get that positioning? Or maybe do I need to do some reverse Trendelenburg and get the patient? Or the most simplest of things, do I need to lift the bed up higher? How many times have you been right about to intubate and someone suggests to you, oh, would you like the bed to be higher? And you're like, oh my gosh, yes, that would be so much easier. So thinking about positioning even before you push those meds is really important. Set yourself up for success. And then placement with proof. In regards to placement, remember that your paralytic takes some time to work, especially if we're doing rocuronium, it can take up to a minute to work. The whole point of paralyzing the patient is to increase our first pass success. That's been studied. We know that it does, in fact, make us more successful. So give your meds time to actually work. And then if you're going direct, you want to have this view that you see here. You want to have like this perfect best view possible. However, if you're going using video, this seems super counterintuitive, but you want to intentionally give yourself a poor view. And by that, I mean more like this picture down here where the actual chords that you're shooting for is kind of in the upper third of the screen. This way you have room, literally room, to get your tube in. You have room to maneuver your tube, and you can see it coming in from the corner of your screen. I don't know if you've ever been in that position before where you're intubating with a video and you've got like this top view here. You've got this perfect view, but you can't get the damn tube. It like gets caught in the rytenoids, or just for whatever reason, you can't get it to go into between the cords. You can see it perfectly, but you just can't maneuver that tube in. If that happens to you, or the next time it does, I would encourage you to pull the blade out a little bit and purposely give yourself this sort of not the greatest view, and you'll see that tube will slide in. Easy peasy. Try it on the mannequins, like play around with it, get nice and close, perfect view, try to put your tube in, and then do it again with this intentional poor view, and I guarantee you it'll go in a lot easier. We don't need to bag the patient unless their sats are going lower than 93%. That's what they're teaching. We want to bag the least amount possible. We don't want to insufflate that belly, which just leads to higher risk for aspiration and other complications. So no need to bag, don't panic. Their sats can go a little bit low. It's not the end of the world. As long as they're not going below, I would say 90 to 93%. And then we need to use some sort of capnometer, whether that's the color one like we use here, or end-tidal, CO2, which this is a whole nother lecture in of itself, so I won't go over it here, but I really encourage, maybe one of us will give a lecture on it, or look it up, watch some videos on your own, because there's really a lot that can be told, not only from the numbers that you're getting with end tidal, but also just from the waveform. Things like, has the tube gotten dislodged? Is it not in the right place anymore? Was it never in the right place to begin with? Are they having some sort of bronchospasm where they would benefit from albuterol or something? Or is there some sort of hypoperfusion? You can even tell things about their actual, hemodynamics from the waveform of end tidal. So lots to be told from this. I wish we used it more. I think encourage you to read up more about it, but we need some sort of confirmation that right away that tube is in fact in the right place. And then lastly, we have the post-intubation management. I would really encourage you to double check your vent settings. Even if you are just learning this, you don't even know what you're looking at, get in the habit of just looking. It's going to be helpful. You're going to know what the respiratory therapist put the patient on. And then as you get more education about it, you get more comfortable with it, you can start making your own decisions too. Like there might be something, an asthmatic or a super acidotic patient that the respiratory therapist didn't know that was going on, and they didn't do the exact vent settings or respiratory rate or whatever it was that you wanted. So double check your vent. Just get in the habit of looking at it every time. Always get a chest x-ray. Remember to look at it as soon as possible. Make sure that tube is in fact in the right place. Make sure that there isn't any barotrauma, pneumothorax that you created from the intubation. Or sometimes, these, especially a trauma patient, there was no pneumo initially, but you initiate that positive pressure ventilation. It's no fault of yours, but now there's a pneumothorax and you need to do something about it. So get in the habit of searching for that chest x-ray and reviewing it as soon as it's done. Remember to recheck the vitals. A lot of times we intubate patients and we just sort of walk out. We have a lot of other things we have to do. We have to go put in a bunch of orders. The zone is backing up, but get in the habit of sticking around, check your vent, recheck your vitals. Post-intubation hypotension is quite common. There's a lot of reasons for them listed over here, but be aware of it and then figure out what you got to do about it if it's there. We know that hypotension, especially in these super sick patients, is not good, and we want to correct that as soon as possible. And then remember your sedation. We're usually pretty good at that. I think we still kind of suck at remembering the analgesia as well. Okay, so that is the 7 Ps and basically RSI in a nutshell. I think if you take nothing else away from this lecture, those first 3 are the most important. Preparation, pretend like respiratory doesn't exist, do it yourself. Pre-oxygenation, remember 3 minutes of pre-oxygenating at 100% FiO2 plus also apneic oxygenation. And then pre-intubation optimization, make sure that you resuscitate before you intubate. Thanks, guys.